This is April Van Buchen. We're going to go over chapters 14, 15, 16, and 17 in the pharmacology book for Nursing 136. So we're starting with chapter 14, anti-epileptic drugs. In order to understand anti-epileptic drugs, you must understand epilepsy. There's three terms that you should know that are involved in epilepsy. Seizure, which is a brief episode of abnormal electrical activity in the brain. Convulsion, which is involuntary spasmodic contractions of any or all voluntary muscles throughout the body, including skeletal, facial, ocular muscles. Epilepsy. That's chronic, recurrent patterns of seizures. This can be primary or secondary. Primary is idiopathic. Remember what that means? I don't know why it happens, it just happens. The cause cannot be determined. 50% of epilepsy is primary, idiopathic. Secondary is symptomatic. There's a distinct cause. Trauma, infection, a brain disorder can even cause it. There are several classifications of epilepsy. There is generalized. So that used to be called grand mal seizures. It just means a full-blown seizure. And then there's partial onset seizure. That's a simple seizure. And that used to be known as petit mal, P-E-T-I-T, mal seizure. And then there's something called status epilepticus. Does this seem bad? Status epilepticus? Your screen says multiple seizures with no recovery between them. So people don't have time to breathe. They don't breathe, so their blood pressure drops, they get brain damage, and they die. Status epilepticus is an absolute medical emergency. When it happens in the field, people, EMTs used to find people that put stuff in the mouth, thinking if I put something in their mouth, they'll breathe. What happens is they bite it. One of my EMT friends says, I always find people, if they're in status epilepticus, some genius thinks it's nice to put a nice soft big fat wallet in their mouth. It just gets stuck there. I mean, they clamp down and it doesn't help them breathe at all. So don't put a wallet in somebody's mouth if they're having a seizure or status epilepticus. And the interesting thing about continual seizures like this is an epileptic drug isn't the treatment of choice. The treatment of choice is something called diazepam, which is Valium. That's an anti-anxiety drug. So it's interesting how drugs can be used for one thing or another. Anti-epileptic drugs help to prevent seizures. These drugs are called anticonvulsants, and even though a combination of drugs can be used, they'll start you on one thing and then maybe give you a combination of drugs to try. And when you start on these drugs, you guys, these epileptic drugs are usually for life. They're afraid to take you off of these drugs. So, anti-epileptic drugs require therapeutic drug monitoring. You want to give the lowest dose possible for it to work. And the concentrations in the blood of some of these drugs, like phenytoin, which is Dilantin, or phenobarbital, or whatever, these concentrations have a very narrow therapeutic index, which means the amount for it to work is very close to the amount that is a toxic level that can cause problems. So you have to start really low and see if they're having a seizure, and if they still have seizures, you give them just a little bit more and let them try it for a week and see if they have a seizure. So you just give the least amount possible, and then instead of giving them enough to be a toxic level, maybe you add something else in there, a different kind of drug. So then all of a sudden they're on a couple of different ones, but the recipe works. Anti-epileptic drugs slow down all nerve activity and they prevent seizures, any kind of seizures. But they have a lot of adverse effects. For Dilantin, there's a black black box warning, suicidal thoughts and behaviors. So long-term therapy can cause suicidal thoughts and behavior. And also, long-term therapy for some anti-epileptic drugs, like Dilantin, cause something called gingival hyperplasia. I have a picture of it in a few minutes. I'll show you. It can cause acne. It can cause unusual hair growth on the face, something called Dilantin facies. I couldn't really find a good picture to post to show you, but it's very distinct, round facial expression. Very distinct faces. There's a bacool of anti-epileptic drugs. Look at all of these. And there's even more. These are just a few. And they're difficult because there's no common ending, so it's hard for you to identify them unless you know them. Barbiturates are used for anti-epileptics, so phenobarbital and something called primidone. They're metabolized in the liver, and they sedate you. So do you really, if you have a seizure disorder, do you want to take a phenobarb? Do you want to take a sedative? Lots of contraindications, as you can see here. There are drug levels that need to be monitored, as you see here. So anti-epileptics have to have drug levels monitored, any of them. And there are different drug levels for each drug. And there's lots of adverse effects. One of the adverse effects of an anti-epileptic, especially Dilantin, is this, gingival hyperplasia. Look at those gums, they're getting huge, hyperplasia. And it impacts your ability to care for your teeth. So oral care is really important on somebody with a anti-epileptic that has a side effect of causing gingival hyperplasia. The most common drug that causes this is phenytoin, which is Dilantin. So phenytoin, it's a first-line drug. It is the drug for seizure disorders, so they'll give it as long as it works. It has the therapeutic drug level for Dilantin is 10 to 20, so that's a pretty narrow therapeutic index. You have to monitor these drug levels. The drug levels have to stay 10 to 20 mics per ml. If it's 22, that's too much, and that can be toxic. So you want to keep it under 20, but you want to keep it over 10 because you want it to work. So again, the therapeutic index here is narrow, and it just means there's a small range between safe, effective, and toxic levels. There are anticonvulsants. So these are other anti-seizure medications. They're just in the anticonvulsant classification. So there's the second drug for seizures after Dilantin is Tegretol. And people will be on Tegretol if they have too many side effects with Dilantin, if they aren't compliant with the Dilantin. For any variety of reasons, somebody will choose something different, and this might be one. It might be because they are allergic to Dilantin. Here are other seizure medications. The contraindications when not to give these is if there's a drug allergy, for sure. Okay. There's a anti-seizure medication called gabapentin or Neurontin. It is a chemical analog of GABA, the neurotransmitter that inhibits brain activity. It works by increasing synthesis of GABA between the neurons. So it just is they all impact neurotransmitters is what I'm trying to tell you, okay? So Neurontin or gabapentin is also used for nerve pain. So it's for some seizures and it's for nerve pain. It's weird that it can be used for different things, but remember what I said about diazepam, which is Valium. That's an anti-anxiety med, and that's used for status epilepticus. So these things can be used for different things. There's one called pregabalin, which is Lyrica. You've probably seen the commercials on television, if you have time to watch television between your busy nursing school schedule. That is a Schedule 5 controlled substance. Have I explained the scheduled controlled substances? Let me do that. There was a Controlled Substance Act in 1970 that initiated the government's war against drugs. People were taking drugs that were causing them to be addicted or abused. So in 1970, many of the drugs that were at risk were labeled in 5 distinct categories, and they called these categories schedules based on A, their risk for abuse, B, safety, C, their addictive potential, and D, whether or not they had any legitimate medical value. So Schedule 1 drugs have no acceptable medical use. They are the worst ones to take, the highest risk for abuse. Things like heroin, LSD, ecstasy. When it first came out, marijuana was on a Schedule 1 because it had absolutely no medical use. Schedule 2 drugs have a high potential for abuse, but they have medical use, even though they're dangerous. So think of opioids, morphine, Percocet, hydromorphone. Schedule 2 drugs have such a high risk that doctors have to send in a prescription for them. They have to handwrite a prescription. You can't call them into the pharmacy. Schedule 3 drugs have a potential for abuse, but it's moderately low for physical or psych dependence. So maybe some cough medicine with codeine, or Vicodin, or some steroids like testosterone. That has a low potential for abuse. Schedule 4 drugs have an even lower potential. So think of your Ambien, your sleeping pill, your Xanax, your Valium. And then Schedule 5 can be abused, but have the lowest potential. Lyrica is that. It has the absolute lowest potential. And usually these kind of drugs are like diarrhea drugs, cough medicine, and some pain medicine. So many of these drugs don't have interactions with other drugs, they just have an abuse potential. And all of these drugs, the interesting drug that we don't know how it works is Keppra. Nobody knows how it works, but it works. There's some random miscellaneous drugs that could be used for seizures, so there's a ton of anti-seizure drugs, the epileptic drugs. And when you think of nursing implications, I'm going to have this kind of slide for every group of meds, but you really have to think of what specific assessment for these meds. So for these kind of drugs, it would be what I need to know before giving this med, like what are their current medications, what are their drug allergies, how is their liver function, what are their baseline vital signs. If you're prescribing it in the oral form, they need to take these meds regularly every day. They need to take them with meals to reduce the stomach upset that it causes. A lot of these drugs are extended release, so we have to tell them not to crush or chew. If they are NPO for a procedure, we tell them to get an alternative dose because they cannot skip their medicine at all. That's the biggest thing. IV forms, follow manufacturer's guidelines, avoid extravasation of fluids. Dilantin is only with normal saline because it does not mix with anything other than normal saline. Commit that to memory. And tell patients to keep a journal. Maybe they were sick and they threw up after taking their meds, and guess what? They had a seizure that day. Well, they were sick and they threw up their med. That explains the seizure. It's not like the seizure medicine stopped working and you need a higher dose. So keeping a journal is really important. And have them monitor for therapeutic effect. If they're taking medication and then they start having seizures, the therapeutic effect isn't working. They have to monitor for adverse effects too. Mental status changes, visual disturbances, sore throat, all kinds of stuff. Okay, now we're going to talk about anti-Parkinson's drugs. Before we discuss anti-Parkinson's drug, we have to understand what Parkinson's disease is. Parkinson's disease is a chronic, progressive, and degenerative disorder. It gets worse over time. It affects the dopamine-producing neurons in the brain. It is caused by an imbalance of dopamine and acetylcholine. So these are two neurotransmitters. They're imbalanced. It's progressive. It gets worse. There are rapid swings in responses to some of the medications that are given for Parkinson's, so we'll explain that. If you have too little dopamine in your system, the Parkinson's worsens. If you have medication that give you dopamine to treat the Parkinson's drug, and you have too much dopamine, you have something called dyskinesia that occurs. And I'll talk about dyskinesia in another slide. So you have to manage the dopamine that's in your system. And if you have too little, your Parkinson's gets worse. If you have too much, you start having dyskinesia. There's Parkinson's-associated dementia that happens. And there's some tables, 15, 2, 3, and 4, on pages 238 and 239 that might help you understand this stuff too, okay? So Parkinson's is an abnormality in the neurotransmitters. So it's not a normal balance. You may have too much acetylcholine, too little dopamine. You may have too much dopamine, too little acetylcholine. It's just an abnormal balance. And any of that can cause the symptoms that define Parkinson's disease. You have symptoms, excuse me, you have symptoms when you lose 80% of the dopamine. But they can be controlled as long as there are other nerve receptors that can take up the dopamine. So when you lose 80% of your dopamine receptors, you start having some Parkinson's-like symptoms. This slide shows some of the classic symptoms. So one of the biggest symptoms is akinesia. Akinesia is loss of muscle movement. Dyskinesia is difficulty performing voluntary movements. So akinesia is none, like I'm anuric, I have no urine, I'm aphasic, I don't talk. Dyskinesia is something's wrong with the way I do it. So difficulty performing voluntary movements. There's two types. I'm going to go back to this classic symptoms of Parkinson's. So you have rigidity, you have tremors, you're very unstable, you have a staggering gait or a shuffle gait, you're drooling sometimes. So it's not enough dopamine. And the drug therapies are aimed at increasing the levels of dopamine, right? So we're increasing the dopamine, or we're trying to decrease the effect of acetylcholine. Here's the thing with Parkinson's disease, though. There's no drug therapy that slows the progression of the disease. It just helps to slow the progression of the symptoms. So if you have Parkinson's, you're going to get worse. But maybe we can control. The medications that are used for Parkinson's disease, I'm going to call them MAOI therapy. So it's monoamine oxidase inhibitors. That is the class of drugs that inhibit the activity of these enzymes. So monoamine oxidase enzymes. But from this point on, I'm going to call them MAOIs. MAOIs break down the acetylcholamines in the CNS of the brain, so the central nervous system. There are Eldepril and Azilect are very common medications that are used for Parkinson's. There's something called a dopamine modulator. So amantadine is considered a dopamine modulator. It's actually an antiviral drug used for treating the flu. COMT inhibitors like catechol orthomethyltransferase is also used for Parkinson's. Some of these drugs are associated with severe liver failure. So you wonder, why do people use these if they result in some severe liver failure? And it's because you see the effects faster with these. So COMT inhibitors, the therapeutic effect is much faster than other drugs. The effect may be noticed within a few days, and the other drugs take a few weeks. You have to think of the adverse effects. So if the urine is dark, the sweat is going to be dark. So can you imagine somebody who usually sweats clear and they have like a brown colored sweat coming out? They'll be rushing to the emergency room wondering what's wrong with my grandpa who just started this new med. They won't even associate it with the meds. So nursing implications, you need to know that kind of stuff. If somebody has too much dopamine, you want an agonist. And so there are drugs for Parkinson's that stimulate, again, the dopamine function in the brain. So there's lots of neurotransmitter suppressants and stimulators. So the agonists stimulate and the antagonists suppress, right? So here's some of the drugs. Here's another drug. And then there's a very common drug called levodopa that replaces dopamine. So levodopa is the biologic precursor of dopamine required for dopamine synthesis. You cannot give patients straight dopamine because it will not pass into the blood-brain barrier. And there is a med, there is some synthetic dopamine that you use. We'll talk about that in later chapters, because you definitely do not use it for Parkinson's. Use it for life-sustaining efforts. So dopamine does not pass the blood-brain barrier. And even so, fake dopamine or non-human produced stuff is called exogenous. So you have endogenous, which means it came from myself. So maybe I have some cartilage that's autologous, so it came from myself. Endologous, it came from another human being. Exogenous, it came from something else, like pig cartilage. But when you talk about drugs, exogenous is a drug that was supplied from something else, created in a factory or a lab. So the blood-brain barrier doesn't allow exogenously supplied dopamine to enter, but it allows levodopa to enter. So once levodopa enters the blood-brain barrier, it magically transforms into dopamine. And then it's released as needed. So as a result, the levodopa helps control that neurotransmitter imbalance in early Parkinson's disease. So if I still have functioning nerve terminals, then I just need to have more dopamine in my body to make them work, to transmit the messages back and forth. I can be given levodopa, and it can help me. It works for maybe 5 to 10 years. Levodopa is effective for maybe 5 to 10 years. And then it wears off. When the patient is seriously debilitated and that Parkinson's is so bad, levodopa is not going to work anymore and they have to get something else, or those symptoms just come back and show up. Remember what we said? What I said earlier, Parkinson's is debilitating. You're just controlling the symptoms. Levodopa is a wonderful drug. Now, the reason I have carbidopa down there with the note of given with levodopa is because, okay, so when you have levodopa in the system before it gets to the blood-brain barrier, it can get broken down just being transported. So the carbidopa is given with the levodopa. Carbidopa doesn't go in past the blood-brain barrier, but while the levodopa is circulating before it gets to the blood-brain barrier, the carbidopa protects it from being broken down in the peripheral blood system. So this allows more levodopa to cross the blood-brain barrier and be converted into dopamine. Sinemet is the name of the carbidopa-levodopa combination drug.